Good day, everyone. I'm Xanda Hilger, and I coordinate the North Central Texas Caregiver Teleconnection, sponsored by the Dallas Area Agency on Aging and the North Central Texas Area Agency on Aging. For this Zoom session, I'll be monitoring the chat, and if I can answer some of the questions, I will. Sometimes they're about resources, but may not, probably won't interrupt the speaker until she's finished, but we'll definitely get to all of your questions and concerns. Our topic today is one that's extremely popular. It's about medications, and for older adults, that's becoming increasingly the way they are maintaining their health and their lifestyle and their well-being. Our topic today is polypharmacy and common drug interactions in older adults. Our speaker today is Becky Mahnan. I always swallow your name. This is her third time, I think, that she's been with us. She is an associate professor of pharmacy practice in the Geriatrics and Pediatrics Division and vice chair of experimental programs at Texas Tech University Health Science Center, Jerry H. Hodge School of Pharmacy. An alumni of Butler University, she completed a community practice residency with Penobscot Community Health Center and a geriatric pharmacy residence with Texas Tech University Health Science Center, VA, North Texas. She maintains a clinical practice site at Hendrick Home Health, a hospital-affiliated home health agency focused on improving patient safety through the care transitions process and at home. Her practice interests include expanding the role of pharmacists in geriatrics outside of inpatient long-term care settings, evaluating ways to increase polypharmacy or decrease polypharmacy and caregiver advocacy. I also looked up this time all of her designations. She is not only has a doctor in pharmacy, but she is a board certified geriatric pharmacist, an board certified ambulatory care specialist, a fellow of the American Society of Pharmacists. I can't quite read that. Extremely well qualified for this topic, and we were very fortunate to find her. Welcome again, our Master of Pharmacy, Becky.
Thank you. Yeah, it's American Society of Consultant Pharmacists.
That's
That's the
it.
one that's on there. So it's kind of like the geriatrics group. Let me make sure that these slides want to share.
Yes.
All right. And it stayed as the slide, correct?
Uh-huh.
Okay, I will get us started. So thanks for joining today. As Xanda mentioned, we'll be going through polypharmacy and some of the common drug interactions in older adults. Everything is on here as well for all that I do with the school, but I really have a passion for working with patients, with caregivers, in regards to their medications. And so that's what we'll be going through today. A general talk outline for what we're going to go into today. The first I will talk about is polypharmacy, because people hear polypharmacy, and I bet if I asked what does that mean to you, you would all have a different definition of what polypharmacy means. What are some common drug interactions in older adults, and how can I prevent or prepare for potential drug interactions? Because really they might happen and we don't expect it, but then there's also the potential that we can prepare for knowing that there's going to be one that would happen. And how do we do so in advance? Now, the first thing we'll talk about is polypharmacy. Now, there's a lot of potential definitions, and these are the most common ones that you see. The use of 5 or more medications, the use of multiple pharmacies, or the one that I like that's the most simple is just the use of more medications than necessary. Because you could have a patient that being on 3 medications and they only needed one, that could be considered polypharmacy because it's more than they actually need. So going into these different definitions that exist, the use of five or more medications, this is one that has just kind of been universally accepted. If you read different organizations and stuff, they will mention five or more medications. You could have some that say five or more prescription medications. So this might actually be like insurance companies if they are the ones defining who has polypharmacy that receives our insurance benefits. They're only going to have access to what you're taking that is prescription information. They are not going to know if you are taking 20 supplements at home or 20 vitamins in addition to their prescriptions because all that is captured for them is the prescriptions. So they may actually just have that they will identify and kind of put a flag on those individuals if they have more five or more prescription medications. But this definition of five or more is actually supposed to include over the counters and all of those other things, but it's going to vary. So in a provider's office, like if you're going to your doctor, or nurse practitioner, PA, whoever you see, their system might flag if you have five things on the list, and it could be all over-the-counter supplements. It doesn't necessarily have to be prescription, but generally five or more is that accepted amount that you hear. I'm starting to see some definition of it being 10 or more, but I think with the 10 or more, it often is going to be those ways that people take into consideration all things that are being consumed versus just prescription. Or I'm even seeing 10 be defined as hyperpolypharmacy, which is kind of, at least in my opinion, a number that I wish that was like a hyperpolypharmacy, but I have patients that easily are on 30 medications or more. So 10 would even be very much underestimating their polypharmacy that they experience. The use of multiple pharmacies is a unique one when you look to seeing what it is, but this is considered because if there's polypharmacy, if you are not filling through insurance and if you're paying cash at various pharmacies, then you're actually going to be at a higher risk for potential drug interactions if you're not sharing all of that information with the pharmacies that you're going to. And so using multiple pharmacies, getting different advice from different people, getting different supplements at different places that you go to can actually lead to potentially more drug interactions, usually unintentional, just because they don't have all the information that they would need. And so this use of multiple pharmacies is considered to be a polypharmacy thing. It can also be difficult. I know sometimes we really don't have a choice because insurance is saying, oh, here's the cost here versus why don't you use mail order? But it does get really confusing if you're trying to track down where your prescription is or where it could have gone. And then, as I said, my favorite is just the use of more medications than necessary. So if you're taking more meds than you need to, then that can be considered polypharmacy. One of the big challenges with polypharmacy is it can be an indicator that someone likely is experiencing what we call a prescribing cascade. I like this visual because it's a little easy to understand what a prescribing cascade is. Now, this is they present to their provider with a complaint of some sort. By the end of that visit, they are given a medication. And so in this case, the person came in, they have some depressive symptoms. The provider gives them bupropion, and so bupropion, one of the big side effects is that it causes insomnia. Now, because they have insomnia, instead of talking to the provider about, is this insomnia from my medication? Is this insomnia because of my depression? They decide that they're going to have another medication. So this is one that could actually be self-induced prescribing cascade for trying to self-treat that. So now you take something for insomnia or sleep ease. Most likely sleep ease is diphenhydramine or Benadryl, and that has a lot of anticholinergic side effects, which we'll talk about later. And now you have dry mouth, you have constipation, you have foggy brain. So maybe then for constipation, you say, oh, okay, then I will take docusate, so a stool softener over the counter. Well, then what if you end up having diarrhea? And it just can continue from there. But there's multiple side effects, and it really is just the fact of treating with a medication instead of trying to address what the problem is and see if there's an adjustment. So in this example, if the problem was bupropion and it was causing insomnia, in depression, it is usually a twice daily medication. So it could be that second dose, taking it earlier in the day, maybe in the mid-afternoon, just so that it's not as strong by the time you're going to bed. But if they're on an extended release formulation, we also could have stopped this prescribing cascade potentially by just changing it to the morning if someone was taking it at night. So there's various ways that you can intervene, but it does take kind of some of this tracking of working backwards of figuring out what was the original kind of offending agent. But this can happen all over the place. And usually it's we come, we have a complaint, we want treatment for it, and then we end up getting another medication and it continues onward. Tackling polypharmacy. So the first thing that you'd want to be able to do is have a conversation with your provider about deprescribing. So deprescribing is actually, I just talked through that polypharmacy, that prescribing cascade scenario. So it would be considered deprescribing if we identified it when they start that sleep ease and said, okay, you're having sleep ease because of this side effect that you're having with bupropion. If we then stopped the sleepies and said stop taking that, that's considered to be deprescribing. So instead of prescribing, it's deprescribing, as in we are taking the medications away that are causing problems. This is something that's going to be very person specific, and so it's not something that you can just say, oh, this is always the medication that we stop first, because we don't necessarily know which one will be stopped. I'm sharing a website on here. This is called MedStopper. This website, it is open to healthcare providers as well as patients. And you go to this website, it's first going to ask if someone is frail or not. That's not necessarily relevant to the recommendations that it makes, but it's going to ask you. And if you're not sure, you can always just say no to that question. But then it asks you to input the medication list, so the medications that someone is taking. And then it will also ask what it's being taken for. So you put the whole list in there for what it has, and then it will send back recommendations. These recommendations, they actually come back with smiley faces, so happy or sad, sometimes neutral, as well as if it really doesn't know. I find these recommendations are they're driven by how much information you feed to it. And so they seem to have stronger recommendations if you're able to provide what the actual indication for use is. Because if it knows the indication for use, it actually goes through and pulls data and information from studies or guidelines, whether or not these are appropriate treatments or not. And so sometimes if it doesn't know what it's being used for, I find that it's not as good as identifying what could potentially be a dangerous medication or one to consider stopping. Now, using this should never be done without the use of your healthcare team. So, taking this information, going through it, and bringing it back to your healthcare provider to see if there's any that you guys want to tackle together. It should not just be taking this list and then just saying, okay, I'm going to stop taking these medications outright. But it does kind of give you ideas of which ones could be causing you more problems than others, or which ones to kind of easily consider might be easier to stop than others that you have in there. It will allow you to put over the counters. So if you take various vitamins and things as well, you can input that into the list and it will help in putting information together. Mind you, this system knows nothing about the patient, or if you're the patient, it knows nothing about you. And so I know reading this stuff, it will have paragraphs on there as well saying, it might be helpful if someone is having some side effect or if they have a specific condition. So reading that information, it's not going to know. Well, you have to take this drug because you have an allergy to a different drug. So it's not specific to that person. It's just from that list, and kind of thinking about people globally. So you really do need to work with a healthcare provider if you're going to want to try to implement any of the changes, it says. Now, shifting gear to drug interactions that we see. So, common drug interactions. Drugs can interact with all sorts of things. It can interact with other drugs, can interact with food, supplements, disease states. So, really anything can interact with your drugs. I will share a personal story here. It can also be environmental things. So, one of the big I'd consider it a drug interaction, even though we also see side effect, are medications that cause what we call photosensitivity, or that is when you become sensitive to the sun. And I myself recently experienced this from a medication, and I didn't even think about it until a couple days later. And even though I'm a pharmacist, and these are things that I do, and the drugs on the next slide that I'm thinking about, that you don't realize it can be various things that actually lead to drug interactions and then can lead to prescribing cascades or anything when really it could have just been something that we could have stopped that initial drug. But so a drug interaction, drug, food, supplements, disease states, environmental factors, there's various things that can actually be a drug interaction. That is something we can either prevent or we can try to treat it after it already happens. So common medication offenders. Ones that commonly interact with things. So antibiotics are a big thing that interact with a lot of different drugs, food, etc. So with antibiotics, the ones I have on here, so doxycycline, this is one that it binds to things, so it can be something that you need to consider. If you're taking it with milk or if you're taking it with other things, this is also the one that I just talked about, can cause photosensitivity. Metronidazole is something that we have to consider. This has a lot of drug interactions as well. It can also interact with alcohol. And so there can be specific guidelines of when should you resume the use of alcohol because you're not supposed to take it at all while you're actually on the regimen. It is mainly though for the oral one because metronidazole does have topical forms, but if the oral one has a lot of drug interactions that have to be considered, but the big thing is really alcohol. Drugs that alter your heart rhythm. So some of these that alter your heart rhythm, you may see reference to if you've ever read, gone to a website or something to see interactions or read the pamphlets that they give you at the pharmacy. If it says anything about QTC, that's part of, it's when your heart is not beating at that time, but we try to measure how long it is. Because if it gets to be too long, that can be dangerous. So these are some drugs that can alter your QTC part of that interval. A big one is amiodarone, fluconazole, antipsychotics. So various medications can alter this drug rhythm. It can be additive that they both do, or it could just be one. But this is a big thing that often flags for being a specific drug interaction that we have to be thinking about. Sinemet, so carbidopa, levodopa, used for Parkinson's disease. This actually interacts with the biggest thing is going to be protein. So levodopa is ultimately what we're trying to create, so trying to have more dopamine available for individuals. But levodopa and protein are similarly go through a similar metabolism process. And so if you take this drug with a lot of protein, the body is going to prefer the protein and break that down versus the levodopa. And so you're actually going to get less medication if you take it with heavy protein. Challenge with Sinemet is that it makes your gut not feel that great. And so if your stomach doesn't feel good when we take a medication, our automatic reaction is I should take this with food. But if you're going to take the Sinemet with food, which I do recommend, you want to try to limit the amount of protein that's taken at the same time. Our PPIs, so pantoprazole, esomeprazole, there's a ton of these in this class, but they generally all have a similar name. There's even omeprazole, lansoprazole, there's a ton of them. But so your PPIs, what they are doing is to lower the amount of stomach acid that you have. So these have some drug interactions that they commonly go through what we call, if we're thinking metabolism, they call it CYP. So those are your pathways in your liver that help you to break down medications. So a lot of these have CYP as a heavy part of their breakdown, but they can also inhibit it, which leads to drug interactions with others. But the other consideration we need to make is that PPIs alter our stomach acid. And so for drugs that need a certain amount of stomach acid to be dissolved correctly, then that can be a problem with this class. That if that plays into it, that they don't then get dissolved as they're supposed to, then you might not get as much of the medication, or even potentially it could be that you get too much if that basic environment makes it speed up the metabolism. There is bisphosphonates. So bisphosphonates such as alendronate, risedronate. We use these if you have osteoporosis or if you're at risk for it, high risk. And so these as well are not supposed to be used with a lot of food, etc., being administered at the same time. And another big class is our anti-seizure medications. So our anti-seizure medications, things like carbamazepine, valproic acid, lamotrigine, a lot of the drugs in this class, again, have a lot of liver action, as I mentioned before, and they can really either increase that or slow that down, which impacts other medications that they have. They have various times of when they need to be given. So if they have to be given with or without food, that plays into it. And if you take them differently, they're going to act differently on your body. So these are kind of our very common drugs that often have interactions. And if it's flagging for any reason, these are common ones that pop up. I would say the other thing that has a lot of interactions would be anything that causes bleeding. And so that could be even over the counter, like your aspirin. It could be over the counter, such as NSAIDs, so like ibuprofen, naproxen, those have prescriptions as well. Those can be, and then we have so many more medications that we consider to be anticoagulants. So like warfarin has a lot. We're not using warfarin as much though as we used to, but then you got to think about your newer drugs like apixaban, or Eliquis, Xarelto, or rivaroxaban, that all of those do have interactions, but a lot of times the interactions are actually the fact that it causes bleeding, and that can be an additive effect when we're thinking about it. Now, what are some of the interactions that we try to avoid in older adults? So, every time that we are talking older adults, we do have some information that's more specific to older adults. And this is one that they brought together. So, the Beers criteria, this is something that gets updated every couple of years. So, I would anticipate it'll either be updated this year or probably next year. The Beers criteria is published by the American Geriatric Society. There's a link on here that you'd be able to do, and hopefully it's open because usually it's open when it's on there, so you can see part of it. The Beers criteria goes through and says these are specific concerns that we would have for the use of medications in older adults specifically. The table 5 within the 2023 version goes into different drug interactions. Specifically, they get a call out for the use in older adults. So it expands on interactions that are particularly worrisome for population. And the reason it does this is the Beers criteria really is trying to think about what are problems specific to the older adult population. So this is not going to be all inclusive. It's not saying that, that it might not mention some of those antibiotics because the antibiotics are a risk for everyone. This is trying to say, what will you maybe not see in a package insert? What's not necessarily going to be something someone automatically thinks to counsel you on, but that we know our older adults are at a higher risk. And so it's ones that we really need to be thinking about because it can be dangerous. So the ones that this is just it's an abbreviated version of that table 5 that I mentioned, just going into a couple of the different drugs that are on there. So one is your opioids, so your pain medications. And this says the ones that we need to be worried about for interactions include our benzodiazepines, and then our GABA agents, so gabapentin and pregabalin. The risk for this is that there's an increased risk of overdose if they are combined. There's an increased risk for respiratory decline considered, compared to younger individuals. And there's also an increased risk of sedation anytime that these are added together. Now, this is something that if someone is on all of these agents for a long time, the biggest time we're concerned is if there's suddenly a change in how much they take. With our opioids and this risk for overdose, they do recommend that anyone that has a prescription for an opioid, even if it's just as needed, also have naloxone in their home. And naloxone is available over the counter as Narcan, and so that is something that they recommend that you have on hand just in case. Respiratory depression, this respiratory decline is especially noted in individuals that have opioids and benzodiazepines. If you hear about the mistaken overdoses, almost all of those cases are that someone is on an opiate, and that seems to be what gets a lot of the attention. But most of the time, those that have an overdose are on something else as well. So it's usually not just that pain medication, it's the addition of something else to it that leads to an actual overdose. And our older adults are just more sensitive to those as well. Lithium, we do not use lithium that much anymore because we have so many more medications in that class. But lithium is a medication that's really good for bipolar disorder or some other psych disorders, and so it could be used. The drug class that it interacts with is going to be your ACE inhibitors. So those all end in pril. So things like lisinopril, benazepril. Your ARBs, those end in sartan. So like losartan, candesartan. And then your loop diuretics. So that includes what some people might call their water pills. So like Lasix or their furosemide, bumetanide or Bumex. All of these, lithium can become toxic. It's actually one of those medications that we should monitor the levels for. All of these drugs work within your kidneys, and so that is also what helps us to clear lithium from our body. And so these drugs being used along with lithium can lead to more, I'd say, kind of flexible lithium levels that you see, that it's not always consistent if they're taking all of these things. So most likely what we would do is try to get someone off lithium if that's an option. And if they really need lithium and we're having a lot of trouble with their levels, then we may be looking at those agents instead. There is some for non-selective alpha blockers and your loop diuretics. And so this is something, your alpha blockers are things like tamsulosin, doxazosin. Those are going to be your alpha blockers. And these have an increased risk of urinary incontinence in women. So if they're taking both of these are things that make you urinate. And so taking both of the agents at the same time could have an even higher risk of urinary incontinence. If someone knows and is able to consider, scheduled toileting, that can be something. But if an individual is not able to do so, and if they have any issues of getting to the bathroom, it's not always just incontinence. It could also be of not being able to control it. It could be not being able to get to the bathroom. And if someone is not able to get to the bathroom, then that can be something that we need to consider if this is appropriate or not. Because you wouldn't want someone sitting in urine for long periods of time, because that can lead to more skin breakdown concerns. Warfarin, I talked about how bleeding medications are ones that we know have a lot of drug interactions. And some of those include amiodarone, ciprofloxacin, sulfamethoxazole, and TMP. That's trimethoprim, but that's just Bactrim. And then your SSRIs, so an antidepressant. Your SSRIs, things like sertraline or fluoxetine would be ones here. So these all have an increased risk of bleeding, so they can increase your INR level. Your INR level is how we monitor how thin your blood is, and if that number is higher, it means your blood is thinner. So all of these drugs can actually increase your INR, and it seems to be particularly something that older adults are more sensitive to than others. The other class that they call out, they consider these to be our CNS active drugs, so our central nervous system active drugs. And these are going to be because they have a higher risk for falls and fracture. So your anti-seizure medications, your antidepressants, your antipsychotics, your Z drugs, so things that probably the most common is Zolpidem or Ambien, the opioids, and the muscle relaxants. So any of these medications that cause someone to be sedated or kind of tired, these are all medications that we want to try to limit or just be cognizant of the fact that older adults do have a higher risk of falls and fracture with these. Now, one thing that we have to consider, I think about for my younger patients, because I do have younger patients, even though geriatrics is my specialty, it could be something that I would say, okay, this one's probably going to make you really tired or it's going to make you really out of it. And so my recommendation would be you should take this medication at bedtime because it's going to make you tired anyway. Take it at bedtime. That's a little bit easier. Hopefully, you'll sleep through those heavy side effects. Our older adult population, more of them have incontinence or BPH. Older adults don't sleep as well as younger individuals. So they are much more likely to get up and out of bed during the night. So it may not be the most appropriate thing to say, oh, hey, take all of those 3 medications that make you super drowsy, take them at bedtime. Because if they get up in the middle of the night, they actually have a higher risk of falling. And so that can be a concern that we just have to kind of think about that when we're trying to go through the different medications and what our recommendations would be. Now, the Beers criteria actually specifically says that with these, you should limit to less than 3 drugs. So for all of these classes, it's not saying 3 anti-seizure medications, 3 antidepressants. Their recommendation is actually for older adults, you should limit to less than 3 drugs from all of these different classes at a time. So that can be a little challenging if you're looking at the list here. People can pretty easily be on a lot of CNS medications. And again, it is something that if they've been on it for a long time, they're likely not that impacted by it because your body kind of copes with those new side effects. But if it is something that's newer that they have, or they're just using things as needed, you can be at a higher risk because you're going to be more sensitive to those side effects when they occur. But that is their recommendation, is to limit it to less than 3 at a time. Now, many of these medications that I just mentioned are considered to be anticholinergic, but anticholinergic medications include various other classes as well. Now, anticholinergic is something that if you take an anticholinergic medication, the biggest side effect that we worry about is really going to be those falls, fractures, cognitive decline, and drowsiness that comes with it. but they cause a lot of side effects in general. This is still my go-to favorite visual for your anticholinergic side effects. So hot as a hare, blind as a bat, mad as a hatter, red as a beet, dry as a bone. So it causes a lot of side effects, but the biggest concern is often that falls and kind of that cognitive decline that occur with them. The falls and fractures are a big thing. A lot with our anticholinergics too. You could have some that are just as needed. So I mentioned those as needed can be an even higher risk for falls and things that come with it. So these anticholinergics are another thing that we need to limit as much as possible. Now this list, I know it's a little blurry on here, but it shows you from table 7 of the Beers criteria which ones are on there. It breaks it down by which are the classes that you have, as well as if there's specific ones in that class. So antidepressants. So looking at the antidepressants, you can see on here there's a list, but there's a lot more of antidepressants out there on the market. And the ones that I've mentioned so far, because I talked about sertraline and fluoxetine, they're not even on this list. So being an antidepressant doesn't automatically mean that a medication is anticholinergic. So you'd want to see which ones are anticholinergic within that class, and it just generally means these are ones we try to avoid in the older population. You will see a call out here for doxepin because I don't know if anyone's had a lot of experience with doxepin, but doxepin is a medication that they have started using more for insomnia in the older population. And it's actually really good for insomnia, but it's at these little baby doses, anywhere from 1 to 10 milligrams. But I generally see people on like 2 to 3 for doxepin if they're taking it. And so we actually don't worry about that having anticholinergic properties unless it's greater than 6 milligrams a day. So some of these ones will have specific things that determine when it's relevant or not. There's your antiemetics, so meds that people might use for nausea and vomiting. Your antihistamines, we refer to them as being the first generation antihistamines. The one I always bring people's attention to is that diphenhydramine is on here, and diphenhydramine is available over the counter, and it is in everything. Anything, a medication that says PM, I almost guarantee the PM is going to be diphenhydramine. The other one that you might see in any of the nighttime type over-the-counter products is doxylamine, and doxylamine is also very sleep-inducing, causes a lot of anticholinergic side effects. And I always share the thing, diphenhydramine, something I've never figured out is why is diphenhydramine always hot pink? Like Benadryl itself, just even in their capsules, they seem to have pink involved for some reason, when that's all that they are. And with one of my grandmothers, when she would just kind of wake up some days and be really out of it, she did have dementia, but you could still notice if someone has, if it's dementia or something else that's causing them to be really just kind of out of it. And one day she told us, oh, well, the nice ladies gave me that little pink pill last night. And that's when it dawned on us that we had brought Benadryl and put that in her cabinet because she was having a really bad allergic reaction. And we didn't intend for it to also be used for sleep, but she was having difficulty sleeping. And so the well-meaning person at her assisted living facility had given her some diphenhydramine. But then when she took it to sleep, she would wake up and still kind of have that hangover, out of it type side effect from it. So diphenhydramine is a big thing to watch out for. And often that we just don't realize how many products it's actually in. Antimuscarinics. So these are generally things used for urinary incontinence. So the list is on here, shows you which ones fall there. I would note that oxybutynin, there is a topical patch that's available over the counter. We're not as worried about this when it's not oral for them. So there's other things you want to think about with topical oxybutynin, but anticholinergic is not as much of a concern. Your anti-Parkinsonism agents, so there's a couple there, not used too often. Our antipsychotics are definitely one that we think about potentially having something. They use those a lot for various behaviors as well as other psych conditions that people might have. Your antispasmodics, and then our skeletal muscle relaxants. The biggest one is going to be your cyclobenzaprine. So there's some other muscle relaxants, but the one that cyclobenzaprine or Flexeril has a pretty high risk of causing anticholinergic side effects. And I find with those, it's going to be those things you use as needed that are more dangerous than others. And so cyclobenzaprine is definitely something that people don't usually take muscle relaxants on a scheduled basis, but they often take them just as needed. And if you're using it infrequently, it can have that higher risk of anticholinergic side effects just because you were taking it just kind of as needed. So with that information, then the question is, okay, it sounds like there's a lot that can happen. And are there ways that I can prepare for it or ways that I can try to prevent these from happening? So managing and preventing drug interactions. Having a current list of all medications you or those you take care of take is helpful. And a true medication list should include everything. So over the counters, stuff you buy online, because I know I say over the counter and people assume that means in a store. But I see more and more individuals buy from websites. They could be on, big websites, or they can be specific ones that you saw like an infomercial for. And so you go to that website. You want to make sure that you are accounting for all the different things that someone is actually taking. Fill all medications at one pharmacy if possible. And this is because if it doesn't go through your insurance, then they're not necessarily going to know what you're taking and which ones could be interacting. The insurance systems, if you're billing it, it's probably going to flag and say, hey, this is a problem. But if you're using it at one pharmacy and some's going through insurance and some's going through cash, if it's all being filled at that one pharmacy, their system is then going to say, hey, this is a problem. That you paid for this one, because their system doesn't care how you paid for it. They just know it's fed into their system. It also can be helpful because then if you are looking for a recommendation for something over the counter, then that pharmacy would have your full list of what you have for prescriptions and then could ask you more targeted questions to make sure that they're giving you the best recommendation. Ask the prescriber, so if it's a doctor, nurse practitioner, PA, whoever is prescribing, or the pharmacist in advance for any potential food or scheduling interactions. So if you're on a new medication, should I take this with food? Should I take it without food? Does it interact with any of my other medications that I'm taking? So that I need to know to take them apart from each other. So asking more of those questions to know in advance whether you need to know and change your regimen. Review the package insert. I put this on here and it probably should have a star because sometimes those are really overwhelming and not written in a way that is friendly to understand. But it hopefully would at least tell you if there's big concerns or not a lot of concerns with other medications, but just kind of go through it and see if anything stands out to you that you would want to ask more questions about. And then just be familiar with the classes that we discussed today. So a big thing, like your antibiotics, they have a lot of drug interactions. And we take them for a short amount of time, but that doesn't mean that they don't interact. They still have the potential that they'll interact with other medications. Um, so that's a big one, our anticholinergics, because some of those are over the counter that we would want to think about. And then just kind of being familiar with those and knowing, hey, these might be higher risk, so maybe I should ask some additional questions with these specifically. Some available tools for patients and caregivers. There is drugs.com. So this one, and the link is on there, which again, it'll be sent out after the presentation. This one, you can enter medications and it generates a write-up. It allows you to do it as a consumer or from a professional. So the consumer should be more friendly to understanding what it means. But it's not always. They still could have information on there that you're like, I don't know what that means. And it would always be good to reach out to a professional and clarify if it's actually a drug interaction or something to worry about or not. Then there is a WebMD one. And so the WebMD one, the big thing with this is that I find it really focuses just on drug-drug interactions. It doesn't seem to give you a lot about drug-food interactions or other things to consider. And we mentioned how it's not just drugs that they can interact with. So in my experience, the WebMD one is a little not as strong compared to the others. There are various tools out there in general that you can use. But this little picture up in the corner that says HON code or HON code, this is something that a website can apply to have this on their page. And if this is on there, it's usually, I see it most commonly all the way at the bottom of a page. So scroll all the way to the bottom. And it's usually one of those bottom corners. This would indicate that they requested that their website be reviewed to say that this is medically sound information. So this is a HON code. This is something that you can look at to know that it's not going to be like Wikipedia, that someone just put in whatever information they wanted. This is actually information that should be verifiable information and appropriate information. So that little HON code, if you find other checkers or things out there, is something that you could look for. So a couple scenarios. What should I do if? So what should I do if I think I am experiencing a prescribing cascade? So if you're not able to kind of figure it out, ask if the new symptom could be related to a medication that you are already taking. So ask about that. Like, hey, I'm now experiencing sunburn. Could that be coming from any of my medications where I haven't changed my sunscreen? I know it's not expired. Is there a medication that I'm taking that could be causing that? Or I'm noticing a lot of bruising. Could that be coming from one of my medications that I'm taking? It's really helpful to have start dates on your medication list for patterns. And so I mentioned having a medication list that I've seen more people start putting them just into their cell phone. So kind of what's the medication? When did you start it? Having that information. But even just having a handwritten list, I myself still like handwritten stuff. And so you have a list and you cross it out, but kind of putting that start dates on things and then tracking is going to make it a lot easier to try to identify what is actually going on. But so if you think you're having a prescribing cascade, reaching out to a healthcare provider, finding out could this be from something that I'm already taking? And if so, is there a way around it besides another drug? Because then we could have our further prescribing cascades. What should I do if I believe my medications interact? So if you believe it's interacting with another drug, ask a healthcare professional if their interaction is clinically relevant or if there are any labs or monitoring to watch for. That's clinically relevant. I mentioned a couple times of the website or the database that you might be using. It might not have information specific to you or whoever you're trying to gather information for. So it's important to think through what is clinically relevant. And so an example I see all the time on some of my patients is that it will say they have a PRN, an as needed inhaler. So they'll get shortness of breath. So they have an inhaler that they're supposed to use. Well, there's another class of medications, so are beta blockers that work on your heart. Some of those work also in your lungs. And so if they're working in your lungs, it's a little counterintuitive to be having albuterol plus one of those specific drugs. There's only a couple of them, but it will then flag in my system of saying, nope, you can't take those two together. Well, I'm going to look and see, is this clinically relevant or is it not? So if the patient has been on the two medications for a long time together, then as a healthcare professional, I may be thinking this is not clinically relevant. If I have a patient that started, they were on one of those beta blockers, and now suddenly they are requesting albuterol, or this albuterol that they're taking, they're needing to take it more frequently after starting that medication, then that may be a time that I say this is clinically relevant. And I'm going to follow up with their provider to see if we can switch to a different medication or other things that we can do. So it really is going to be person specific, whether it's clinically relevant or not. If it's related to scheduling, ask how to best take your medications. So if they're ones that they're interacting with each other, can you take them at the same time? Do you need to take them with meals, without? How can you kind of space that for what you can do? And then contact a healthcare provider if you notice signs, symptoms of what you learned to watch out for. So hopefully your providers are telling you, hey, these are side effects where if you experience this, I need you to call me right away because this is something that could be indicating that you are having an allergic reaction and we need to stop the medication. Or it could be that like bleeding, we talked about bleeding medications a lot. Here are signs of what a severe bleed would be. If you start experiencing a severe bleed, you need to contact a healthcare provider and find out what they want you to do. So learning what those are, just kind of knowing those big ones to worry about, and what are times that I should actually follow up. So following up with an individual versus just deciding, oh, I'll just stop the medications, because it could be something that can be easily adjusted or just requires a change in therapy. Now I know some of the things have been popping up, but I don't know if you've been responding. So now I'm going to switch over and start answering some questions.
Becky,
Yes.
could you talk about the term off-label use of medications?
Yes. So off-label use of medications is when the medication has not been approved by a body of some sort, usually the FDA. So in the US, we're thinking the Federal Drug Administration, if they have approved it or not. Generally, off-label means that there are studies of some sort that support its use, either in guidelines or in practice. And so there's enough out there to say this medication is likely appropriate and potentially safe, but it hasn't gone to actually be approved. That doesn't mean that it went and was said, do not use it for that. There's various reasons that some medications might be used off-label versus being on-label. And sometimes it is the cost associated with a medication becoming on-label that there's enough use and enough evidence out there that they choose not to get it placed on label through the FDA because that's not, it's a various process that you have to go through to get indications approved. So you could have things that are used off label that are appropriate to be used off label. They just haven't gone through that whole process.
Okay. And the reason why a physician would prescribe something off label would be what?
So it could be that there's nothing that's approved on label for what that is for.
Okay.
And so then they're going to use something off label. And it could be that the insurance company potentially could say, I'm not going to pay for that. And they
Mhm.
may request that the provider justify why they're using it. And so they might be able to go out there and say, here's a study that said it was used appropriately, or here are all the drugs that they already tried that did not work for them. And so they're going to use this one instead.
Okay. With pharmacists being so busy, um, how, what do you suggest we do about asking for a consult about your medication list? Do
Yeah.
they?
Yeah, so pharmacists definitely are busy. And so it could be something, if you have a pharmacy that you work with regularly and you really want to be able to, I would say sit down, but that's not necessarily sitting, kind of like meet with that pharmacist
Mhm.
and kind of ask some questions. If you have flexibility, you could also be, asking them like, hey, I did have a couple questions. Like, here's my question for today. But
Mhm.
is there a time during the day that you think is kind of better
Mhm.
if I wanted to be able to come in and maybe actually talk to you for five,
Mhm.
10 minutes just to get some more information. And they'll probably be able to tell you, like, oh, we're not as busy on Wednesday,
Mhm.
and kind of help guide you into that information. I would encourage if you're able in person is probably better for those just because they can kind of help to actually get over there and answer your questions. And if they have to step away, it's not as intrusive as if you're on the phone trying to do those things. But pharmacists do want to be able to help you. And I know that a lot of them are being pulled in various different directions that they have. But kind of just working with them to see what it is. If you already have that information together too, of like, here are all my medications. As for me as a pharmacist, that's a lot easier. If someone says, hey, I had this list. I'm going for surgery soon, and they told me that I shouldn't be taking anything that can thin my blood. If you come up to me and you have a whole list of all the over-the-counter supplements that you're taking, various things that they may not have thought of, then I can go through it quickly and tell you, oh, that garlic could be thinning your blood. But if I already have that information and I'm not having to ask all the questions, it's just going to make it more efficient and give you more information too.
Okay. We have a question. How does CBD use, oil, and gummies interact with other drugs?
hmm Yeah, so CBD, this is the easy answer is that CBD can cause some of that. I talked about like CNS depression. And so it's something that we wanted to think about if someone is known to have that. They recommend that we kind of stay away from CBD in individuals that have a history of Parkinson's, because they know that it can interact with Parkinson's disease and some of that neurologic impact. But CBD in general it's very product specific, like how much CBD they're actually getting. I'm generally not as worried about topical things. The oils, I know some of those are oral, some are also topical. They can cause a little bit of blood thinning if they're taking a lot of CBD, but it's generally not a lot of blood thinning. When it comes to CBD use, my recommendation is when you're trying to pick one that you want to take, there's some companies. So if you're using an over-the-counter product, there's this little thing, I showed you the HAN code and I saw that you were saying some of the ones that are HAN certified. There's actually something called a USP. So like United States Pharmacopoeia. This USP is something that could be on a supplement to say that, yes, this is actually what it says. But CBD, because it's not considered a supplement or like a vitamin or something, it doesn't have that available. But if you go to CBD, the different manufacturer websites, they can actually apply to have their stuff certified. And so if you go on there, you can go and try to find that information to verify what is in those different products because they send it out to an ulterior lab and those labs verify what it has. But so the interactions, the biggest thing is going to be the CNS depression, and it's mainly with our oral forms.
Mhm.
But it's
Okay.
also important to make sure you're letting your providers know that you are utilizing CBD.
Hmm. The next one is a comment, and it's a personal one. My
hmm
husband's been in the hospital and in a long-term care facility, and it demonstrated twice now I've had this experience would encourage all of you listening, be prepared to carry a doctor's orders for complicated drug protocols.
Hmm.
My husband's on a fairly complex pain management program. And when he was transferred to the long term care facility, they made a unilateral decision to remove one of the medications. And so I contacted his physician, and the physician called them not very happy. But if I'd had a written order, which he then subsequently scanned and got over to that. But if you've got something like that, and it does happen for many older people, complicated protocols. And some of these facilities, they've never seen it before. And so it doesn't fit in the column box that they know. And just be prepared that you have an official doctor's order. You can always get it from them, but what if it's a weekend?
Hmm.
But that's
Yeah,
like a
having that information and also just a list of who all the providers are so that you
yes,
make sure they're talking to all the correct people.
yes. Um, and I just didn't, this has happened to me now twice. And
Hmm.
so I've now learned my lesson. I was going to mention also our familycaregiversonline.net is a Han certified website, and that's where you'll find not only the recordings from Caregiver Teleconnection, but a wealth of information, resources, and online education, frequently asked questions. We do a lot of blogs. Um, so would encourage you to go over and check that out. On your screen, you have a session survey. It's 8 questions. And that information, take a few minutes to do that because that information is valuable for us to know about how you're viewing the programming that we're providing, and also to give you a chance to give us an idea of what you'd like to know more about. Any other questions? I've got two new questions.
Yeah,
We still
I was
have
gonna
a
answer
few.
that first one.
We still have a few minutes. Uh,
Hmm.
do the pharmacists know more of the interactions between over-the-counter vitamins, minerals with medications?
I would say of all your health professionals, your pharmacist probably knows the most because we are the medication expert on the team. And if they don't necessarily know offhand the answer, they're well trained in how to find that information. So
Mhm.
we might have access to additional databases and things, different tools that other professionals might not be looking at to see what those are. Because it's not even just vitamins and minerals. I think about all of the supplements are often the ones that I have to go and look that up for information. But I can usually find it and give you good guidance. There's a couple of the systems that we would have access to as pharmacists that help you run interaction checks with prescriptions as well as over the counters that your other providers might not be using.
Okay. Other questions? I think that's it. Becky, if you were to summarize, and this may be a difficult question, if you were to summarize the most important message for family caregivers in terms of medications and polypharmacy, what would that be? What comes to mind?
I think the most important thing is that medication, like a new medication, should not always be the answer.
Hmm.
If it comes down to it, honestly,
Hmm.
that if someone is experiencing something new or has a new complaint,
Hmm.
that the answer should not automatically be, oh, here's an additional medication.
Hmm.
That actually trying to see what the other stuff is.
Hmm.
Um,
And very often, as we know, that medication may be being prescribed by another physician, and there's
mhm.
not a coordination. They may see your list, but there's not a coordination of that. And so I think that was very important for um, to understand there may be other options here.
Yeah.
That's a good comment. Folks, I hope you have um, got the benefit. I always learn something, always learn something when Becky talks to us. And so um, you might want to go back and review the YouTube, the video when it's out. And so you can learn a little bit more. Thank you so much for your time
Thanks for having me.
again this year. And everyone that's listening, thank you. Take care of yourself. Self care is so important for caregivers. Easier said than done, but what would you tell your best friend?
Mhm.
Which is take care of yourself. Finish your survey if you would. Thank you very much. And we'll close now.
Bye. Thank you.
Bye, Becky.